Good afternoon once again. I'm Sinia from Palliative, India. So that I'm keeping my video off due to some network issues. We welcome you to the foundation course in palliative nursing. Thank you all for joining us today. Today we will be having our first session in foundation course in palliative nursing, that is on introduction to palliative care. Before that, I'm introducing you to the structure of our course. This is our 15th foundation course in palliative nursing. So the number of sessions, as all of you knows, is 18. And we are starting on 10th April 2023, and that's today. Am I audible?
Yeah, audible.
Okay. Our end date program is 12th June 2023, and the class timing is between 3 to 4:30 p.m. We will be having sessions on Mondays and Thursdays, except public holidays. And we have a prescribed syllabus, and we have shared the pre-test questionnaire from our end. I think most of you have completed that. And a case presentation by a participant nurse on each session will be there. Today, we will be having a case presentation on our first session. You can take it as a model case presentation. And we will be sharing the resource materials with you. All the learning materials will be uploaded to the IECO platform, that is ieco.org. And you can log into your particular IECO account and access all the learning materials. And there will be 6 assignments in total. It's mark based. There are no examinations, but 6 assignments in between all the sessions. So there will be a post-test questionnaire and end evaluation for the assessment. And it will be on the after the sessions completed. Raju, can you please move the slides? And the certification eligibility or the mandatory clauses, we need a minimum of 80% of attendance in person. And if you are able to keep your video on throughout the session, it will be so good. And completion of 6 assignments with a minimum of 70% marks for each. A minimum of 70% of marks is a must for completing the assignments. And submission of one patient story or case presentation. I have already shared the case presentation notes with you and the case presentation template. As I have already told, we will be having one case presentation today, so you can take it as a model case presentation. And attending pre-test questionnaire, post-test questionnaire, and end evaluation. There will be one feedback form shared with you after the session. So all of you should complete the feedback after each session. So, and how to join the session. All of you have joined the session throughout the IECO platform. So I think you all know how to join for the program now. Next slide, Raju. So case presentation. Case presentation is mandatory for certification issuance at the end. And we have shared a PowerPoint format from our end for the same. Each participants need to come up with a patient story among the 18 enlisted session topics. I have shared it with you. You can select in your own and send it to us. Send it at our mail ID tipseco@palimindia.org. And we will be having a case presentation from our end from the start. We will be having one today. If you are not presently working or not having direct exposure to any patients, you can bring in any old patient story which you feel is relevant to the topic chosen by you. Anyway, you have to send one case presentation, and if it we will be having discussions with our faculty panel, and we will be selecting one case presentation appropriate for the session. And all the learning materials will be uploaded to the LMS platform IECO, including the recorded video links of the session, faculty presentation, and other PDF documents that will help you in completing your 6 assignments. All these can be downloaded and kept with you. Next slide. So about accessing IECO, most of you have completed the IECO registration. I think there is no need to further discussions about that. Next slide. Thank you. This is a common introduction for the course, and without much delay, I'm handing over to our facilitator, Sister Sheba. She is the division head of virtual education in Palliative, India. She is dealing with the on-site training programs mainly. She has 18 years of experience into palliative care. Welcome, ma'am, and over to you for further introduction.
Thank you, Senia. Very good afternoon to all. A warm welcome to the foundation course in palliative nursing. So as Senia said, you have to maintain the rules and regulations for entering the course, and you have to switch on your video all the times. If it is not possible, please let us know if you have any problems. We prefer through the video mode is on. So this is the online training program. So we need to see you all. So today is our first session. This is introduction to palliative care. You all know that this is the first session. This session will be taken by Dr. Radha Venkatesan. So who is a palliative care physician and had many years of experience in palliative care. And before that, she basically is an anesthetist and had worked in United Kingdom and Saudi Arabia. And since last 2 years, she is volunteering with us. That is one of the major gift for us. So she was came here and worked with us last 3 months. Now she is in UK. Ma'am, happy to see you again, and welcome to the new training program, and over to you, ma'am.
Thank you very much, Shiva. All thanks to God and Pallium for accepting me as part of their family. And as Shiva mentioned, I've been enjoying every minute, both doing online sessions and being there with them. I would say like cherry on the cake was being with them. Okay, it was an excellent time I had. And let's go ahead. I'm really happy to see the whole team. And as it has been mentioned, this is the first session today, and I hope all of you will enjoy, benefit, and be effective palliative care practitioners. That is our aim. Okay, and for that we are all going to work together to achieve it happily, easily, successfully. Okay, thank you. I can either share the presentation from my end also, so that whatever would be better. What would you say?
Okay, ma'am, you can share it from your side.
Okay, then. Can you all see now?
No, ma'am. No, ma'am.
1 second. One second, dear. Now can you see?
Yes, ma'am, we can see you. But at the same, yes, perfect.
Okay, then. Warm welcome to all. We are going to see what is palliative care and how are we going to practice palliative care. Okay. Okay, first, where from have we got this word palliative care? Pallium is derived from a Latin word meaning cloak or cover, but the verbal or verbatim dictionary meaning means relieve without curing. See, this is very, very important. From here itself, it starts how are we going to understand palliative care. So, relieve without curing. So, cure is not the only outcome or only way of managing a patient. Okay, so relieve without curing is what is the verbal meaning. And from there only the whole palliative care meaning, understanding, and taking it forward has taken place. Next, just we need to know what and how the world is at present to know where we have come and what we are going to do. So this is some statistics, which is an eye-opener for all of us. In today's world, non-communicable diseases like cancer, dementia, renal failure are the ones which are increasing. See, in very, very olden days, infectious diseases were the primary cause or the problem. So that was some time where infection, antibiotic discovery and managing them, that was the prime problem. But in today's world, what is the problem? Non-communicable diseases, as mentioned above, they are the main issue. So, and what has statistics shown? It has been estimated that 1.5 billion people experience some form of chronic pain around the world. And that could be 61 million in total who need some form of care. So they all need some form of care. Long-term, short-term, whatever it is, some form of care is needed for them. And next point, see, death is inevitable. But in today's era, what we have done, science has improved so much, the longevity has increased. So when the longevity has increased, some problems come as part and parcel of it. So how are we going to manage that? And next important thing, all of us talk about quality of life. Am I having a better quality of life, or just living, is that a quality of life? So in that place only palliative care comes in to improve the quality of one's life, especially even in his last days, and tries to decrease the burden of the disease also by doing the care itself. Next, what is palliative care? Palliative care improves the quality of life of patients and that of their families. It is just not the patient that we are going to look into. We are going to take care of the family too, who are facing challenges.
Session join chedo.
Hello?
Dr. Radha, you can continue.
Palliative care improves the quality of life of patients and that of their families too. So this is important. See, it is not the patient alone whom we are going to take care. We are going to take care of the patient and the family, because together only is one entity. And both together only are facing the challenges. And so it is for everyone who is facing any life-threatening illness, or even recently what they say, some form of long-drawn illness. Not only life-threatening, any form of long-drawn illness which needs care. And in that, it could be physical, psychological, social, or spiritual. Any of those challenges, what can we do for it? So, and the next thing, quality of life of caregivers also improves as well. As I said, we are incorporating the family. Family means a caregiver. It could be kith and kin, or next of family, sometimes even friends. So anyone, so we are taking care of the patient and the caregiver too. So next, just overall palliative care can be a home-based palliative care or a hospital-based palliative care. Both are possible. Both are possible by itself or existing together also. Then comes a little bit of history. Because see, where did all this start and where are we today? Okay, for that, the prime person who started was Dame Cicely Saunders, and this is just a small timeline, okay, for us to know how and where we are. So first in the 1950s, It was James Cicely Saunders who articulated the idea about modern hospice. How did she do? She did this on observing patients who were dying and caring for them and things like that. Basically, she was a sister, then she did her medicine, she became a doctor, and then she is the founder person for the whole of palliative care. And then in the 60s, what happened was a psychiatrist in the United States called Elizabeth Kubler-Ross. She had to face a lot of repercussions when she was trying to look after patients dying, giving them autonomy, giving them their preference, what did they want, and trying to do that. It was not easy. So at that point, she released a book, which was a book on death and dying. That opened the eyes for so many people all over the world. So that was again a milestone. Then in 1974, an oncologist in Canada coined the word palliative care. His name is Dr. Balfour Mount. So that was the milestone done in 1974. And then in 2006, the United States accepted palliative care as a specialty. And then regular input of training and everything was done. And latest information for India, what I would say is, at present, at least 6 universities have recognized courses for palliative care, and also other diplomat of national board and things like that. So palliative care is recognized now as a separate entity, and you have curriculum, training, everything incorporated in the Indian curriculum also. So all over the world, not in one place. See, any problem is not a problem in one part. It's an issue all over the world. So the importance has been given, and it has been taken as part of curriculum. So anyone and everyone can get trained in palliative care, because that is what we will need down the line. Okay. Next is some fundamental aspects of palliative care. What are they? What do we need to know? It provides relief from pain and other distressing symptoms, affirms life and regards dying as a normal process. Can anyone overcome or say that I can be without dying? It's not possible, but it has to be made or conveyed to people in a proper way, that is also part of life. So make that also as a normal process and give care, love and affection even at that point of time. Okay. And then next is, it intends neither. This is the important point, what I'm going to say now, because that is where still many people don't understand what is palliative care. So it intends neither to hasten nor to postpone death. We are not doing any change to the death per se. Okay. Quality of death only is we are trying to give. So this is what, this one point, if all of you take also from today, will be a big blessing. Okay. Next, it integrates the psychological and spiritual aspects of patient care and offers a support system to help patients live as actively as possible until death. So if some of, as we go through, we'll see if some of the symptoms are relieved, they can have a peaceful, happy life, not that they have to struggle all along. And it offers a support system to help the family cope during the patient's illness and in their own bereavement too, and uses a team approach. See, one-man show will not work in this. Okay, so it has to be a very good, well-managed and well-set team approach to address the needs of the patients and the families. And we also include bereavement counseling as and when required. By doing so, what will happen? Will enhance quality of life and also positively influence the course of the illness. Everyone see what happens if someone goes through something that has a mark. Whatever we go through, we have some memory or something about it. So if it was a very tough, wrong episode, what you will remember? The same thing, if it was dealt in a better way, what would be remembered? So by doing so, not only for the patient, for the family also, you give a better experience, so that not only for that period of time, afterwards also, see something, all of you know what is something called as post-traumatic stress disorder. What is it? How we go through some situation and what is the impact of it? It gives to that person's life, to the carer's life. So doing a better quality of care will give so many benefits, not only to the person or the patient, it will give to the entire family. So indirectly, you're helping so many. Okay. Another thing is that not that you start palliative care at the fag end. Okay. Is applicable early in the course of illness in conjunction with other therapies that are intended to prolong life, such as chemotherapy or radiation therapy, and includes those investigations needed to better understand and manage the distressing clinical complications. So I will show a diagrammatic representation also, how what I've said here will be explained in more detail also. So it has to be started as early as possible. And so that when you do so, the treatment also continues. And the palliative care, that is, palliative care is managing the distressing symptoms. So what happens? The treatment continues, distress is also managed, so they have better quality of life. So next, life-threatening illnesses, be it cancer, neurological, respiratory, or cardiac. It could be any of them. It is not only cancer. That is one important thing to understand from this. So that's why palliative care is not only for oncology patients. It could be for any of these which I've mentioned here. And in that, the ones on the right side, they can have a physical symptom, a social problem, a psychological issue, or a spiritual health issue, or it could be some patient issue or the family issue. So many things. All these individual things can be part of each of this for a cancer patient, for a neurological patient, for a respiratory patient, or a cardiac patient. So all these can be there. Okay. So each one can have one of them. See, for example, a cancer patient may have just something to do with the family alone, or a psychological or a financial alone. No other issue. Everything is fine. So something like that. So both of these have to be had in mind. Just to ask, do you feel, am I going a bit too fast? Do you want me to slow down or anything like that? Or is it okay?
I think this is okay, ma'am.
Because generally I'm a bit fast nowadays. I've tried going slow a bit. So I just wanted to double check. Thank you, Shiva.
Okay.
Okay. Next is what we'll see we have seen so many aspects. So we'll see what are the individual things that can be there. Physical aspects, what all can be there. Could be something to do with pain, weight loss, dehydration, some infection issue, or shortness of breath, nausea, vomiting. These are all things. And tissue viability. See, any patient who has long-term bedbound, tissue viability, wound, they are all very, very common. Pressure sores, pressure ulcers. So they are all very common, and you may think they need not be bedbound for many, many months, even for few weeks. If they are not moving, not doing the right thing at the right time, can cause issues even in a week. Week itself may be too long. Okay, so what do we do then? So managing those symptoms in a multidisciplinary. See, for example, nursing care has to be there, and then you have to see if, for example, that patient needs air bed or something like that. See, I'm trying to give it with clinical examples so that it makes sense to all of us. Okay, so in that case, nursing care also has to be taught. Then the next thing, what you think, oh, financial some issues there. Is there any way that patient can get an air mattress? Or if they can afford, we can at least educate them. See, many times, many may not know. Oh, just by lying down will it happen? Because awareness is a very, very important thing. Not everyone is well read. Okay, so like that, so many aspects are there. You have to work together. That is why it is this team working again and again, what I'm telling will be very important. When you work together, you will get the benefit, and your workload or burden will be less. So you will work happily. So manage these symptoms in a multidisciplinary setup with good communication with the patient and caregivers. So we have to tell them, see, some simple issue of pressure just lying on one side. No, you put some support, turn them again and again, turn their position once in 2 hours, how to do that, teach them, literally physically teach them. Just imagine, oh, they will know, all that will not work. Okay, both to the patient and the caregiver. If the patient can mobilize some little bit, but not fully, so you can tell them, you yourself turn around. Or if the patient cannot turn, then you tell the caregiver what. So that's where communicating is so important. And next thing is that when someone is really very seriously ill, explain to them what will happen as due course. And to them, because they may not even know how it will be and how things will change. So you take time, explain to them, and all that you don't do on day one. Okay, take your time, get some rapport. The patient and the family have to have faith and belief in you. So it has to be a two-way thing. Take 1 or 2 consultation times to see. You go visit them first day itself, you tell everything, it'll be going overboard. Nothing will stay. So take time, explain, see where they are, see what they understand, and then keep on doing. And so when you explain to them and do that, second time when they do and see the benefit, they will be more willing to accept information from us. So at those point of time, explain to them how things will turn, and slowly, don't scare them also. Okay, but convey the message so that they are able to utilize and give the best care to their loved ones. Next, psychological and spiritual aspects. Psychological and emotional distress is very common. And what are they? Fear, depression, worthlessness, guilt, and paranoia. Everything in this is so important. Fear of the unknown. Okay, everyone is scared, so they imagine all unwanted things. So that is the cause. So explain to them, don't worry, everything is. See, one thing I would like to convey. Everyone reads and sees all nonsense. Okay, not that every patient goes through all difficulty. Okay, so that is one hope you can give. So that is one thing for fear. And worthlessness, why? Because they think they are unable to get up to, see, I am only a burden to them. No, those times you can say, see, for example, one simple example I'll give. As parents, they would have looked after their children. Do they say when the child is naughty and not doing anything, they look after them? So they can say it's just a reversal of role. Why do you think you're worthless? You did everything for your children. So children are doing for you. Don't ever think. So these are little things which you can give and tell, which will help them not to feel worthless. Okay. And paranoia, fear and guilt is that, oh, I did some mistake. In those situations, what you say, okay, you've done. You're unable to rectify that now. From now on, don't do that. Why do you need to have the guilt? So for all these things, explaining to them and giving some information, this is all what? Just spending time and looking after and caring for them. Okay. So as I've said, you address these with get the help of if you can, well and good. If not, get the help of a social worker, psychologist, someone like that. Then next, spirituality. That also is one of the important things. So for that, you do some assessments, because that also is taken as part of palliative care. And you have to respect individual patient, individual person, regional belief, concepts, everything. Don't go and say totally, no, that is wrong. You try to say what is best for them, in that what support you feel. Okay. And from that point of view, many studies have proven that if someone has some strong spiritual belief, they face like their issues, any palliative care issue is faced and dealt by them better off, and they get better quality of life. So in this, basically you will be having some session, or you can further on read on it. Like religion is different, spirituality is different. I'll just give a quick broad definition alone. Religion is faith and belief. Okay, faith, belief, practice, that is religion. Whereas spirituality is what is meaning of life, what is purpose of life, that is spirituality. So this is the two broad definition you need to understand. And from that also you get help from local, whatever is available. What is that the patient wants? That's what you have to see and then take it from there. And if you give that, they will cope with the situation better. And then it is proven internationally that it is helpful, and it is part of, like when we see anything as total, spirituality is also part of it. So what is our aim? It is to support the patient and family wherever it may be it in hospital or at home, and to improve the quality of life and enable a dignified death. And so next, okay, I said all this. Why is it not happening? Okay, what are the barriers for palliative care? All what I'm telling here are all WHO information, okay? I'm not cocked it up from anywhere, okay? Why? What are the barriers? They say the national health policies and systems often do not include palliative care at all. This is all international figures, okay? And then training on palliative care for health professionals is often limited or non-existent at all. Is this considered as part of training in our regular curriculum or in your regular work? No. Now, slowly some eye-opening is happening, but this is not as part of regular. So, and then population access to opioid pain relief. Again, this internationally, they say, even though opioid is available, opioid access to the patient who needs it is still not reached internationally. And everyone is trying their level best. Maybe opioid is available in most of the countries, but is it available to every nook and corner where it is needed? No. So that part still the whole world is struggling to achieve. What are the other barriers? Lack of awareness among even policymakers, health professionals, public. So that is why we need to raise awareness. We have to convey the message to the public in some form or the other. So see, even for example, in your own families, or many may not know. So I have some friends who tell me, oh, it'll be nice. That is non-medical. Say, whenever you do something, let me know. I will also join because I don't know A, B, C, D of this. So like that, this awareness is lacking and it has to be incorporated as much as possible to convey. Then cultural and social barriers are still very, very strong. And to break that, it will take time. And for that, one thing will be, you should try to, in every area or region, there'll be someone, even though that barrier is there, one person will be there in that group itself who will be willing to change. And fortunately, if that person you are able to access, that is where change can be brought in. And misconceptions about palliative care. This is one very strong, wrong thing taken or known by anyone. It's only for cancer patients. It's only for end of life. That is not the basic thing. So these issues are there even among professionals itself. So first we have to have a big mountain to climb. Okay, so we have to take the effort, and God's grace, you will succeed. The effort may be a bit more, the needed effort may be more, but the barriers have to be broken by taking attempts. So misconceptions have to be broken, and then improving access to opioid analgesia will lead to, they have that the misconception, oh, morphine, to use morphine itself, many are scared. Morphine, if you say, they always think substance abuse, oh, addiction. No, there again, a strong or clear message has to be conveyed. Okay, how the morphine is used is what causes addiction. When you take morphine orally, it will not cause addiction. Only when it is smoked or injected or the route of administration is what causes the substance abuse. Okay, because morphine has been used for cancer pain, non-cancer pain for many, many years. For cancer pain, morphine is the gold standard. There's still, why all of us know gold standard means that is the best. And when it is taken orally, none of these substance abuse things happen. Even the side effects of respiratory depression and all doesn't happen. We have been using it. I've used morphine for chronic pain for more than 10 years, from 2008. And I've used morphine for cancer pain from 2017. So umpteen patients we have used, and the benefits benefits are more over than the risk. So in any of these, you see what is something called as risk-benefit ratio. So if you see like that, the benefit supersedes the risk. Okay, so this is something has to be conveyed by us. Only when we know that we can convey. So that is another important thing. And then next, what can countries do as recommended by WHO? Health system policies that integrate palliative care services into their structure and giving financial and financing. See, many people say, why is it not incorporated? Oh, we don't have funding. This is a standard thing. No, because anything done in a good common cause needs some funding from somewhere. So that has to be incorporated by the countries on the top level. So that's what is happening. No, in many places now, palliative care is incorporated into the medical teaching, and then through postgrad. As I said, there are postgraduate courses available. So like that, slowly things are improving. Next, putting some policies for strengthening and expanding human resources, having training as part of it, having some, like all this is happening in all your, community health care centers and all. You have palliative care, at least a small wing is there. So slowly we are getting there. So if you keep on doing, raise awareness, improve availability, things will improve. So educating, re-educating, and having manpower are some things. And then next is medicines policy, making sure that medicine is available first, and then it reaches the patient where it is needed. And especially with opioids, two main important things is it is very, very beneficial in pain relief, and it has also been found to be useful in respiratory distress. So those are things, correct usage, correct dose, everything is there. Not that some things you cannot do without knowing. That is why this training is so important. Okay, first you should know what to do, how to do, where to do, when to do. Then you will be able to provide the best service. So what is the significance of palliative care? So as I said in the beginning, it has to be started early in the course of the illness. And it not only improves quality of life of patient, but also reduces unnecessary hospitalizations and use of healthcare services. Okay. Unnecessary hospitalization, in that, what do I mean? If something is really needed, if the patient's outcome, like what can be, normally we say in palliative care, always correct the correctable. If something if there's an infection which can be corrected, yes, hospitalization is what will help. If for example, IV antibiotic, no, you can give IV antibiotic at home, you can have at home itself. Okay, so you balance. If it is needed, go to hospital. We are not telling don't go to hospital. Don't have anything wrongly understood. So where and when needed, we will do 200%. But if that hospitalization is not going to benefit the outcome, so in that situation, you decide and then make the call. So the healthcare service can be used appropriately. Where needed, you will go. If not needed, you will not go. That's all. This is what I was mentioning. So please concentrate on this. If you see this whole picture, on the left side, you have something called as presentation diagnosis. So that is the point when the patient is diagnosed with some issue, you take anything. Okay. So at that point of time, you see the white part of the graph. That is some form of curative care. If it's a cancer patient, it could be chemotherapy, radiation. If it's a non-cancer patient, medical management, interventional management, anything. Okay. The white bit is that, and the yellow bit is the palliative care. So both of them are starting hand in hand. The white portion is more, yellow portion is less. Okay. So it is going on like that. As it goes on, see, this is a general natural process. Okay. If you take it as a neurology patient or a cardiac patient, one stage of their life, whatever management you give may not be beneficial. Okay, that time the white portion is reducing and you need conservative management where treating the symptom, for example, cardiac wheeze or breathlessness, there you need to correct because cardiac ejection fraction is 20. Can we change that now? Maybe you do heart transplant, you can do. If the patient can afford transplant, well and good. If not, what happens? So at that point of time, the symptomatic management increases. So that is where the LO bit is increasing, symptom control supportive care. Okay. So it just goes hand in hand. And then as it goes, finally, when the patient is really unwell, that hospice care is not, it is one thing mentioned there. So the palliative care covers the whole LO bit is palliative care. That hospice bit alone is not palliative care, is what you have to understand. So through the illness, you have the curative management and the symptom control happening hand in hand. So by doing so, few benefits are there. You come to know the patient more. Okay, and you can do the symptom control, they can do the curative management. So you are helping your own professional also, helping the patient, helping the family. So many benefits are there. One important thing is working as a team. That is what is very, very important. It's just me managing. I can do everything. That's why there's a golden statement. There is no I in team. If you work together, you will definitely succeed. And in that phase also, but when patient gets to a stage where curative treatment is not going to be possible, that is where full time, there you can make a call, whether the patient wants to be at home, hospital, everything like that. There we'll see also the difference between home care, hospital care and things like that. Then finally is bereavement care, because still you have the carer and the family. We have to look after them also. So that is why palliative care, bereavement care is also part of palliative care. So this one slide is very, very important to remember. Anyhow, as Shiba and the whole team have said, you will get the presentation and you can go through, get back to us any doubt, anytime you need. So pain and difficulty in breathing are the two very, very important serious symptoms experience, because they are distressing symptoms. Okay. And then how you manage them? You manage them with opioids. And then it is used for breathlessness, as I said. And it's our duty to relieve their symptom. Okay. And I think they will deal in detail, because for pain, you use different dose. And for breathless management, a different dose is used, entirely different. Okay. So, but it is our duty to look after. And if you alleviate these two symptoms, it is said generally 80% is this. So these two form big chunk. So treating and managing them is important. Next, what is hospital-based care? We'll see what is home-based care also. Hospital-based care, varied setup from, you have in one hospital itself, you can have outpatient, inpatients, daycare. Daycare is generally used for chemotherapy, radiation, those type of things. And then you have a multidisciplinary team in the hospital itself. You'll have a social worker, a psychologist, physiotherapist, everyone there under one roof. Okay. So all those are there, and nursing, and then you can do wound care. So all of the above are available in one place. So that is hospital-based care. What is home care? It's a form of palliative care that provides all the basic needs. There also you get physical, psychological, moral support, everything, who is suffering. And it could be anything. As I said, why I'm bringing this again, cancer, lung, to remember that oncology or cancer care is not the only thing. Even dementia patients. Okay, and is provided by a trained multidisciplinary team of doctors, nurses, social workers, physiotherapists. Volunteers play a very, very big role. And as whatever is needed, and care provided is in part to one received in hospital. That is something you have to see. That is where you have to train and get a team to be in part to the one in hospital. That's what. Okay. So what is the importance of home care? I've just put it as two perspectives. From patient's perspective, what is it? From carer's perspective, what it is. From patient's side, it gives them a big peace of mind. Okay. When he dwells in his own environment, I'm in my own home, because even in that we have done big, I was part of a small audit survey nearly some 7-8 years ago. We asked patients, what is that? Where is that you would love to be when you're really unwell and you're about to die? 85% wanted to be at home. 85-90% itself wanted to be in their own home. I don't want to be anywhere else. So if you're able to do something at home, that is the best for them. And why? They have their kith and kin next to them. When someone is in ICU, no one is able to go in. Nobody is able to even be next to them. So is that what? Put your finger on your heart and see, is that what you would like? I would not like. Okay. So even though I am an intensive care physician, but I know the in and out of it. Even if you're not an intensive care physician, you can know you're seeing, no? You all see your own family, your friends or relatives, so many things. So this is what came out of the study itself, that 85-90% wanted to be at home. So if you're able to provide that service at home, what not? That is the best, and I'm able to get that. Okay. Patient gains confidence when he's getting his treatment at home, where the family members are taking an active part in it. And so this guilt and all sometimes won't be there. Oh yes, it is my son coming and doing, I'm happy. Something like that, maybe their worthlessness, they may not feel. So because one day or the other, they may sit and chat. Okay, it may be a running race every day, but one day suddenly the son or the father or the friend or whoever it is, the carer and the patient may have a conversation, to have time to have a conversation. Okay, these are the benefits from patient's perspective. From carer's perspective, what? The role of family members who come forward to take care. So they say, oh, I want to do something. And then physical, psychological, financial is considered to be important too. So they themselves will figure out how we can help them too. Okay, the home-based care services ensure continuity of care for patients and empower the caregiver in the family by teaching them simple and cost-effective methods. See, again, in this, no, I'll just tell one or two things, and the nursing team will take you. We teach them to do a full dressing care at home with all stuff available at home. They need not buy anything. This again, I've been doing all along this 5 years of doing this palliative care, and I have seen patients improve. Not a must you have to go and buy everything from the pharmacy autoclave. You can autoclave at home. And mouth care, we teach them to make solutions at home and use it. Wound care solutions are made at home and taught. So all this can be done, okay, in simple, cost-effective way and efficient. Don't think, okay, it is done at home, because even that is a myth. It's done at home, so it may not. It may be better off than what's like that. There are some things which can be taught to the patient for better care, better quality, better price. Okay. So those are things. Then finally, what is the success tool? First, we have to pass the information, educate the whole team, and the communication has to be done properly. There has to be some changes, like good, bad, everything has to be changed to work in as a team. And important, communication has to be done appropriately, nicely, no rude. This I say, you follow, those type of things will not work. It should be a two-way communication. And so communication has a great role to play in the success. So how you convey, what you convey has an important role. So every body language, and what are you taking time to convey the message? Are you conveying the correct message to them? Are you clarifying the queries, what they have? Many times, and because they may not even ask the query, they may be scared. So you have to gain confidence with them for them to raise their queries and then for us to clarify that. So everything is important. So generally, how can all these be done appropriately? These are some generally we say, these are things which can be taken, like your information has to be correct and it has to be complete. It has to have everything, not only the plus, minus, everything. Concrete, you have to tell them this is how it is. How are you telling? Yes, by my experience, I can say. And then at the same time, don't go on beating down the bush. It has to be complete, I said, and it has to be concise also. Neither you nor them don't have too much time. And then coherent, don't go say what is not relevant. And then, as I said, courteous, we have to respect everyone. We have to respect them and we have to be respected too. You also need not be taken for a ride and then be disrespected. And then finally has to be clear. It has to be transparent. So if all these are there, it's better for you and for us. And just one more thing I thought of telling. See, if palliative care is understood and done, the knowledge is gained and practiced properly. And in that case, what will happen? It will be fulfilling for us to render proper service to the families and also give them the confidence that we will know none of our professional doctor or nurse will abandon them when treatments fail. We will be able to help them as much as possible at all times and relieve their suffering. So that is what has to be conveyed. So the nutshell importance is what I said now. So the training has to be attained by us, then help to raise awareness to the public and the patient, so that to give confidence to them that, okay, if treatment possible, we'll treat you. If when treatment is not possible, we will cure your symptoms and give you support and care till the end as much as possible. So that is the important thing. So finally, what are the learning points that we have learned today? Early involvement of the multidisciplinary team plays a vital role in overall patient satisfaction and well-being. Patients should be given full autonomy to make informed decisions and their confidentiality to be strictly practiced. Early involvement of psychological, spiritual support, everything, whenever, whether mental support or whatever, will give you a better quality of life. The family and caregivers of patients should be kept informed and involved throughout. No hiding anything from them. And their opinions and views also have to be taken into account. It is important to treat distressing symptoms at the end of life also. Anytime, whatever, whenever symptom relief is needed, it has to be done. So we have to work as a team. Team working is what will give success. Okay, so that is something to be followed. And we have to learn to work as a team, because as we have seen today, no, all the symptoms and things can be relieved only when you work as a team. Because I cannot be psychologist, I cannot be social worker, everything. So when we work together, better success can be achieved. So let us all work together to be able to provide the best possible service. Thank you very much.
Thank you, ma'am.
Thank you.
Thank you, ma'am, for the wonderful session. Anybody need any more?
Any queries or anything?
Thank you,
Ask
ma'am.
any.
Thank you, ma'am. Thank you, ma'am.
Okay. So
Thank you, ma'am.
if you have any questions, please ask her. Any?
Yes, go ahead and ask. And
Yeah.
If you have any question, answer. Two question left. One answer that one.
முடிஞ்சிச்சா தம்பி அவ்வளவுதானா?
If you don't have any questions, I will ask questions.
No, ma'am.
No.
No, ma'am.
Okay. So I would like to ask one question. When will you start palliative care?
Ma'am, right from
What
the
is-
diagnosis.
Yeah, what is
The early
the,
stage of illness.
sorry,
The early stage of illness as soon as we diagnose.
okay. Any other
Ma'am,
point,
right,
any other answers?
ma'am, right from the diagnosis.
Okay. Why do you think like that?
Why do you think like that?
To reduce the symptoms and
Okay, from the point of time you were saying like you have to start palliative care from the point of diagnosis, right? That is correct. So why do you think like that? From the point of diagnosis, that time they need curative treatment. We are focusing on the symptomatic management. So now we are telling like, okay, you have to start from the point of diagnosis.
To maintain the quality of life.
Okay, so the main aim of palliative care is to improve the quality of life.
Yes, ma'am.
Okay. Any other comments? So, Madam has explained very well the process of palliative care and all, when we start palliative care and all. So we need to start from the point of diagnosis. You have to think about the patient's side. So when a patient's diagnosed with a cancer or incurable illness or a life-limiting illness, so they need, actually they need curative treatment. At the same time, they will be having a lot of psychosocial issues and these spiritual issues and all. So and also ma'am was telling like it's a total care. This is palliative care is a total care. So the same time, if you give a palliative care or a supportive care along with the curative treatment, definitely we can improve the quality of life, because from the palliative care team, we have to give a proper support, and we can able to listen their problems. We can able to give some directions and give some opinions, and that kind of things will be helpful for them. And so that will be improve the quality of life of the patient and their family, because if they have some kind of illness there, they will be having a lot of psychosocial issues and other problems and spiritual distress also. Nobody is there to listen their problems. We are all focusing on the physical problems. Just think about, if they, for a cancer patients, they need to take a chemotherapy. So what are the side effects of chemotherapy and radiotherapy? Do they get adequate symptomatic management for that? So that is why, if they take chemotherapy or radiotherapy from the hospital, maybe a regional cancer center or any other specialty hospital, at the same time, they need a symptomatic management from your side. So that time, if they will get a good symptomatic management for the problems, definitely they will go for the next chemotherapy or the radiotherapy. Otherwise, they will reluctant to go to take the next cycle of chemotherapy. And I have many many patients like that. Because of the side effects of the chemotherapy, they reluctant to take the treatment, and they will stop the treatment. They had stopped. So if you give a proper guidance and give a good supportive care to the patient and their family, definitely they will continue the treatment. So that is why we were telling like you have to start palliative care from the point of diagnosis. So I think all other aspects ma'am has covered well. And
just one thing, Shiba. First, next thing, no, they will be aware that there's someone there to listen to them and talk to them and help them. Because Shiba said, no one knows. So, and then other teams may be concentrating only on that chemo or physical thing. So first thing, they'll be normally thinking, oh, no one listens to me. There's no one I can go to. So that can be taken away. So they know that you can tell them, oh, we are here to help you if you need anything to. See, many times, not only in medicine, for anything and everything, will you all not feel that better off if I know I can go to someone? So that is one big help and support which they will have. And you gain a rapport with them. So they will open up and tell you, many times they might not even told to their own family. They will come and open up to you what is very, very secretive to them. And you may be able to, not that you are a big expert in solving anything. Through some help or other, you may be able to help them. Some financial, you can link somebody else, some education need, or something like that as an example I'm telling. So, which will take away the whole problem for them, because for them, their disease might not have been the issue. Their worry about solving something else was the issue that gets solved, and they'll be willing and more happy as a person. So, you being there to support them is a big help for them. It will be.
Yes, that's true, ma'am. And one more thing I would like to add along with that. Here we need to understand that nurses are spending more time with the patients, and if they have a physical, psychosocial issues there, definitely they will have some kind of physical problems will be there. But along with that, if they have a psychosocial issues there, definitely the physical distress will increase. So that we need to understand. Okay. So otherwise, if you give more, so many medications, but we are not able to control that physical problems, that because of maybe sometimes they have some other aspects also, like some psychosocial or spiritual issues will be there. So we have to explore that and address that concerns. Then only we can able to reduce their physical symptoms. So that is the another things we need to understand. Okay, we can move on to the case presentation. Sister Masley Joshua will be presenting a patient story today. Sister, over to you. Sister Masley, can you able to see the slides?
Yes, yes.
Yeah.
Can you hear me clearly?
Yes, yes.
All right. Hi, I'm Maslany from National Cancer Society Malaysia, Sarawak branch. So today I will do my case presentation. I hope we can all learn together. Can I have the next page, please? So for this patient is a 66-year-old female diagnosed with relapse of multiple myeloma. So the presenting complaints for this patient is she had slurred speech, and then she cannot move her arms. She's able to move her arms. The power is 2 to 3. Unable to move both legs. So both legs are edematous. Sometimes it is, sometimes it's not. And then she has poor oral intake, general pain, and unable to pass motion, bowel opens. So history of this patient, she was diagnosed in 2013. Unfortunately, she had a fall in July 2022. So MRI was done and then noted there is multiple compression fracture, T12 to L5, and then with vertebral body with thoracolumbar spondylosis. So since that fall, the patient was unable to ambulate. So she had frequent breakthrough of back pain despite analgesia. So recently, for past 3 weeks, she is having poor oral intake and she looks weaker and weaker. She unable to pass motion and become delirious for about 1 week. So she talked incoherently, and then at times she cannot recognize a family member. She also had right lower limb swelling and slurry speech. Okay, upon examination, her lungs are clear, her abdomen is soft but with sluggish sound. She's unable to move both legs, and then she is on diaper already. So she only managed to pass motion after given enema 2 tubes by the doctor. So her pulse was 86, her blood pressure was 98/69. During that moment, no shortness of breath. For her treatment, she had failed multiple lines of chemotherapy, and then you can see that that's her blood result during that moment. Psychological aspect, she has 4 adult daughters, all married, all having grandchildren, all married with children. So she lived with her husband in a double-story terrace house. All her children are living in the same area except for one who is living, if by plane, is around an hour flight like that. So previously she's an educator. So her medicine, she's on fentanyl patch, aquasmorphine, syrup lactulose, suppository bisacodyl, tab bisacodyl, sublingual lorazepam, haloperidol, and pregabalin. So main concern for the family here is her pain management, her nutrition wise, and then her risk of getting pressure sore, her ADL, and family support. So in summary, this patient is a very short-lived, from the time we receive her to the time she passed on, it's only a day. So she passed away a day after visit. And then we did attended her rosary prayer as requested by the family. But the family did share that they were grateful because towards the end of her life, we managed to share with them the signs and symptoms. So the family members, all the daughters and husband and children are able to be with her. They did not go back to their house because they see the signs and symptoms already. So they managed to speak to her individually, and then they were able to comfort her and even prayed together for her during that last moment. So in summary, the family experienced a normal grieving process. So these are some points that I would like to discuss. Maybe I would like to know what is Dr. Radha's opinion. So for this patient, how do we care for patient who is unable to express themselves as they are slurry and at times unresponsive? Like for this patient, she was already slurry to the point that she's unresponsive at times. And then because of the short duration, we haven't been able to establish a good rapport with her. And next one is how to assist family members to care for dying patient when they are still in denial. Like despite it's been a long diagnosis, but then they didn't expect the mother to pass on within a short period of time since the fall. Yeah. So that's.
Okay, thank you, Masini, for the wonderful presentation. Anybody need any more clarification regarding this patient story? Please ask her. We all understand that this patient is no more, but we can discuss. We will see. Sometimes you might have seen these kind of patients in your settings future also. Anyway, we will discuss these patients. Before that, if you need any clarification regarding this patient story, please ask her. I hope this presentation is clear to everyone. Then we can move on to the discussion points. The first question is, now we understand what is palliative care. The first question is, how do we care for this patient who is unable to express themselves as they are slurry and at times unresponsive? So please suggest put your comments in the chat box, or you can unmute yourself and talk. Madam, over to you. So we are waiting for your response.
For this, like I am Anantavashni, so we can use like types of communication charts in which they can easily communicate, and we should also like understand what is they are feeling, what is their need, so that we can give our feedback immediately to the patient. So this is one way. It's like very important here is the communication.
I think that if they can, I'm Renuka from Sri Lanka. I think if they can get some help from some occupational therapists, it must be great, I think. To the communication skills and keep the between the patients good rapport and some facial expression like something.
Yes, I would just add on one thing here. Very good. I'm happy that you're all giving, like, see, the communication tools, occupational
Yes.
health, very good. One more thing what we can find out is, see, it is new and short time for us. But the patient, and there would have been someone with whom the primary carer would have been with her, and they will know, even though slurred speech, they would have had some form of communication between them. That can also be used. Okay, so that to see that how were they communicating? Sometimes even like pain or their need, they may be denoting with some signs. So what we have like standard or tailor made up, like we have fixed things for these which can be used, which are tools. And sometimes what the patient and the carer were using can also be known from them, and that can be used also. Okay, because that is what the way, the state we see the patient. Especially thank you for bringing up this case, and even though it was short time, no, see, there's no rule that this is how a case or something will be. That is the biggest plus point and the challenge for our medical profession. Everything will not be the same. And something new comes up every day. That is what is the challenge and the attraction to our job. Okay, so those are things also to be kept in mind. From the patient and family, you can get some information. How were they communicating? What was it? So you build up on that also. That's something I thought of adding on.
So any other points you want to add? Please go back to the main concerns. Yes, this was the main concern of the patient and the family. So pain. So I would like to ask you about the pain management. Did she get adequate pain relief with the medications and all? So what about the nutrition? What did they ask about the nutrition? So that kind of things I would like to know. So definitely these patients need palliative care from the point of diagnosis. At the same time, we need to give, our aim is to improve the quality of life. Once we reduce the signs and symptoms only, then only we can able to improve the quality of life. So we need to give the adequate symptom management as much as possible. So that is why I'm asking you, what about the pain management and all?
For this patient, she was on fentanyl page 37.5 microgram, and then she was on aqueous morphine 15 mils PRN, 15 mils around. So for this one, we basically look at her pain scale based on the grimace of her face, and her daughter did say that there are times that when she grimace, then she would give her more morphine like that. Yeah. And then in terms of her nutrition, because that time she can't swallow already, so we did tell the daughter that we can keep the mouth moist, the lips moist, and we try to drip a bit of fluids through the mouth. But we also explained that towards the end of life, because she can't swallow, because there's lack of energy and all, so it may not be safe to feed her solid food. At the same time, we assured the family that despite not giving her food, her body would still be able to she would still be able to use some of the calories from her own body, because culture-wise, family are always worried if their loved one are being starved, or are we hastening their death or making them suffer. So this part, when we talk to the family, eventually they agree that she doesn't look like she is uncomfortable or hungry. For the pressure sore part, because it was the initial part, we have already, she's already on Ripple mattress, and the time when we saw her, there wasn't skin break, so we explained to the family that they need to do turning for her, and also at the same time using barrier cream to avoid pressure sore. For the ADL, we did give them a list of home care nurses if they need extra private help, and then or other services that they can engage in to care for the mom at home. So I think in terms of family support, the family, they are quite supportive. So because that was kind of the initial part, and it just went downhill pretty fast. So the family support, they need to basically organize it. It's there, but they just need to organize it. Because for this family, for this lady, after we visit her, she was referred to us. Day 1 referred to us, day 2 we visited her, day 3 she passed on. So it was quite a fast moving event. So that's why the second question is, how do we help family when they are still in that denial phase, and they are still slowly trying to process the situation?
Okay, thank you. Thank you for your response, because here we need to understand that this patient prognosis is not good. At the same time, we need to give a symptomatic management. They make the patient comfortable as much as we can. So here we were discussing about your pain management of this patient, and this patient was not able to talk fluently because slurred speech will be there. So that time you have to focus on the non-verbal expression. You can listen, observe their that may be facial expressions. When they will be moving the patients, they will their faces like that kind of things. The facial expression will be there. We can understand from that point. And before that, we can give some pain analgesics before turning. It will be good to give some analgesics and for instant pain, and then you can turn the patient. That kind of things we can do. And the another thing is nutrition. So we anyway pain for the pain session we have a two session on pain. Introduction to pain and management part will be there. That time we will discuss more about that. And coming to the nutritional part, we need to understand that food is a symbol of love. So always the caregiver will be that force the patient to eat, and they are more comfortable to give some kind of food to the loved ones. So if they are not able to eat their light food, so that things they will not be tolerate because they will be depressed. So here what you can do is you have to arrange a family meeting and explore their concerns, because we need to listen their worries first. Why they are usually they will come with you and give, maybe you can put a rice to nasogastric tube, or you can give the total parental nutrition, or you can give a pint of fluid. These kind of things will be there. They will be asking frequently, please do something, these kind of things. So what you can do is you can call a family meeting and you can discuss their concerns first, and you have to respect their concern, and then you can tell them. So if you give these kind of things to the patient, that will not help your loved one. That important message you have to tell them. If you give a total parental nutrition to this patient, it will not help it will not help the patient. That will be helping to the cancer cells. The cancer cells will take the nutritional parts. Okay, so that important things you have to tell them and make them understand that. So this is not a good option. And as you mentioned earlier, that sips of fluids, or you can lubricate the mouth and that oral mucosa, that is enough for the end of life care situation. And pressure sore, definitely we need to prevent pressure sore. We have a session on that, pressure sore, that prevention, how we can able to prevent, what are the causes, what are the management, these kind of things will be there. So we will discuss later on that. And family support. Definitely this patient, the caregivers need a family support, because they are going to lose their loved ones. Okay, so this is a big loss. This is a big loss, because we need to think from their side. They are going to lose their that important person, and one of the important persons in their family. So we need to listen their worries and tell them that. So you, as much as possible, we will give a good care to the patients and make them comfortable, and this kind of reassurance is very, very important here. Okay, and
I think that this patient is needed some spiritual support too, no? Spiritual support with the family support. If he had some spiritual support, like this is an elderly woman, and it will maybe help, no?
Definitely spiritual support is good, but you have to you have to give their choice, because their beliefs, and we need to follow their beliefs and systems. So if they do some belief, they need to maintain some things for spiritual things. We need to allow them to make it happen. So what do you think, ma'am, Radha ma'am?
Same thing. A couple of things, Shiva. All what you have said, we are going to deal with them separately in each instance. Pain, also I thought of preempting, we say, giving something ahead, 1 hour ahead or something before doing. This all will be dealt in detail. And from spiritual support, totally true. Yes, they need support. It will help them. But we should not go against patient wishes, because we don't know what is that family's intent. So for the second point query also, Same as the first one, same for nutrition. For nutrition, no, nutrition, denial, everything, the background or the reason is love. Okay, love shown in different ways. See, love itself can be helpful, can be harmful also. Okay, so in that way, but we can't say that directly. We have to sit and talk with the family, get to know what is their worry, what is their concern. Tell them, yes, you love them. We can also help you to do that. But by showing love and affection, we cannot cause harm. That is where we have to convey. Okay, for nutrition, we can say, as we said, is this nutrition going to help them to get better and become all right and fine? Then I will do. It may not do that. So it will not meet our purpose or your purpose of curing and getting the patient back on their feet. So that can be explained. And then spirituality, as I've said, we can talk to them. And if they say, yes, we will need, we are happy, then we can also jump in, get someone, or we ourselves can give. So that is the answer for spiritual support. And then the third question, the second question, what you had, denial. Denial again will take time. Okay. And for this patient from 2013, the problem has been there. Okay. But see, many times denial can be there for long. And if you see, it will be someone, again, the most loved one, who will be causing great amount of denial and not letting anything happen. Okay. And at that point also, slowly, by having family discussion, you will find out what is the main cause of denial there. And then you go to that root cause, sit and talk with that person, or if it is many or whatever. Again, in these type of things, communication, again and again. But we cannot, they may not reveal. First time you have to sit and talk to them and explain to them. And then always I say, when you are listening to me, everything may not come up. Go back, sit and think or talk, come back. We are ready. So first day they may not accept. So second day they may come back and tell, yes, I'm only finding it difficult. So then try to help me. Then we can help them. See, this is the problem. This is the issue. We don't see, many times they have guilt only. Oh, I should have done better. Nothing like that. So you have done all whatever is possible, but still the disease supersedes. And because it was in this stage, it was in final stage. See, especially with her, with neurological, so many involvement and things, multi-system involvement, multi-system failure. So when you explain all this, when there's multi-system failure, overcoming, then you have to give some statistical figure or something. That's where, again, team discussion, MDT or multidisciplinary team discussion, will say, when there has been 3-system failure, outcome being positive is not possible at all, is something inevitable. So if we explain to them, then the denial will go. Then they will accept. It is matter of time, patience, but sometimes no, there's not enough time available for them to. So that is where, if you had started early, you have gained rapport, things will be easier. Many times what happens, you see the patient at the wagon, they are worried, they are distressed. But even in those situations, there will be, not always, but most of the time, there'll be some indications the patient is really unwell. Patient is in end of life. So that time, one discussion or something may not be enough. Even in that 24-hour period, you may have to talk to them a couple of times. So first time you say something, second 2 hours later, when you see, yes, this is what. So we have had these type of situations when we have seen patients. And every time matters. For example, I'll tell you, we saw a patient who the daughter was in total, this happened in Palliative only when I was there. The daughter was in such denial that she was not even involving the rest of the family. Thank God that day from 10, patient was deteriorating. 10 o'clock, we spoke to them. And she herself came around and said, yes, I do accept. So then she got hold of her brother and her dad's sisters and everyone. And then everyone came within the hour. And then by 2 o'clock, that patient died. Okay. But this girl had so much of peace and quiet. She said, oh, thank you for talking to me that minute, because she literally got everyone in within the next hour. And then the whole family was there by 12 o'clock or half 12. And then 1:32, that patient died. But see, that's all. It's multifactorial are there, but it can happen. We spent nearly from 9 o'clock to 11 o'clock talking to her 2 or 3 times. Because we picked up that she was literally doing everything by herself, not allowing anyone, but that won't work, isn't it? It's her father, but the father has brothers, sisters, everyone has a role there. As I told you, if I give these examples, they will come up to you when you face patients. See, all this training is what? One day you're all going to go see patients on your own, and you have to be able to manage. And you can manage. It's not, see, all what we have learned, we have to streamline, put things in its place, and then have faith, belief, and go work, and you will be successful. Did your queries get solved to some extent?
Yes. Thank you, Dr. Radha.
Yes, ma'am. Thank you.
Thank you,
Good.
ma'am.
So that's what. And always Palliative is there for all of you to help anytime. That's another thing to remember, okay? It's such a lovely organization that anytime you need anything, this you don't find many times, okay? So please utilize, benefit, and be successful.
Thank you. We can wind up the session.
Yes, Shiva.
Yeah, ma'am was discussed earlier. This stage we call test collusion. So we have a class on the communication in detail. We have 2 sessions on that. That time we will discuss on that. We need to break the collusion also. Sometimes and positive denial and negative denial will be there. So we need to treat, because if they have a denial there, sometimes the important thing is you don't take it as a challenge to understand, because they, as ma'am has mentioned earlier, they will understand gradually. Definitely the symptoms will be worsened, and the prognosis is not good. From these patients, this patient's prognosis is not good, but gradually they will understand. So if they have a denial, please don't take it as a challenge. So that's the important message. You have to understand that. And the collusion, if they have a collusion there, definitely we will educate them. You have to explain them, make them understand the importance of breaking the collusion. And we will learn how to break the collusion and all. Now today, I hope you all are understand about palliative care. Palliative care should start from the point of diagnosis. It's for the patient and the family. You have to understand the family problems also. We need to care the patient family. The caregivers also important, because we need them because they are the person to take care of the patients. Because so we need to look from the patient caregiver level also. And the another thing is teamwork. So without a team, we can't do. So we need a doctor, we need a nurse, sometimes we need a physiotherapist, sometimes we need a occupational therapist, sometimes we need a medical social worker. If they have a psychosocial issues there, definitely we need a psychologist or a medical social worker about to explore more problems. So we need a teamwork, and also this is a total care. So we will look into the physical problems, psychological problems, social problem, and the spiritual problem. Then only we can able to improve the quality of life of the patient and the family. Okay. Thank you, ma'am, for the wonderful session. Thank you, Maslenia, for attending the case presentation. That is a good presentation from your side. Hope this presentation is helpful to everyone. Please try to do the case presentation next the next session onwards. If you have any difficulties, please let me know, or let that seniors knows, we will help you. Okay, thank you.